Navy physicians Captain Dave Harlan and Lieutenant Commander Allan Kirk from the Naval Medical Research Institute in Bethesda will discuss a very significant research results on preventing the rejection of transplanted organs, which is crucially important to anybody who has to have a transplant. So here they are. Thank you for waiting.
Thank you for the introduction, Mr. Bacon, and good afternoon, ladies and gentlemen. Lieutenant Commander Kirk and I are here to discuss a significant advance in the transplantation field, findings to be published in today's Proceedings of the National Academy of Sciences. Namely, using non-human primates, we have tested a new method to prevent the rejection of a transplanted organ that does not require continuous anti-rejection medication and that may liberalize the criteria used to identify a suitable organ donor. After my introductory comments here, Commander Kirk will communicate further details about our studies. For at least 3 reasons, it is appropriate that we make this announcement here at the Pentagon. Most immediately obvious to you all is that both Commander Kirk and myself are Navy Medical Corps officers, and the research we will be describing has been performed using Navy assets and long-term Navy sponsorship. Less immediately obvious is that our work is defense-related, in that we study the immune system, which is the body's internal system of defense. But I think the most important reason is that we believe the products we're developing will prevent illness and/or save the lives of U.S. servicemen and women. Let me also say at the outset that the general principles that Commander Kirk and I will be discussing here have been worked out by investigators within the Navy, but also by many other scientists outside the Navy. Science at its best is collaborative, and most advances, no matter how dramatic in appearance, tend to be incremental. And that is certainly the case here, as we have built upon the work of many fellow immunologists. Now, having said that, for the past decade, investigators in the immune cell biology program of the Navy Medical Research Institute in Bethesda, Maryland, have studied the body's defense system. We have sought the ability to direct the body's immune defenses with the same specificity and control as warfighters can now accomplish with their sophisticated weaponry. And I'm pleased to announce that to a remarkable degree, we are making progress toward that goal. We are working on ways to educate the immune system such that we can mark specific targets like various infectious agents or eventually even cancer cells to the full destructive power of the immune system while leaving untouched neighboring cells that are not infected or are not cancerous. On the other hand, and the main reason we're here today, many illnesses are caused when the body's defense system is misdirected and begins to attack self-organs or tissues. And in addition, many different injuries or illnesses that could otherwise be cured by the miracle of transplantation are today left untreated because of a too limited organ donor supply and because of our as yet imperfect means of preventing transplant rejection. I'd like to spend just a few minutes describing in the most general sense the basic principle underlying our efforts at directing immune function before turning the podium over to Commander Kirk. Immunologists now generally accept that most complex immune responses are directed by a special class of white blood cells called T cells. Indeed, it is these T cells that are lost in individuals with advanced stages of the HIV infection. T cells have a very difficult task. They must be able to recognize the wide variety of infectious agents that exist in the world today. And this recognition is controlled through a sensor on the surface of the T cell called the T cell receptor, indicated here. T T cells use this T cell receptor to recognize differences, however subtle, between normal cells and cells that are infected or cancerous. This is also how T cells distinguish one's own organs from those transplanted from an organ donor. It used to be thought that if a T cell recognized a target as foreign, that T cell would undergo an activation process, trumpet the alarm, and marshal all the immune system's forces to destroy that target. Over the past 20 years, it has become clear, however, that simple recognition alone does not stimulate immune destruction. T cells also have on their surface other sensors called co-stimulatory receptors, shown here, that in essence serve as the immune system's on-off switch. For the immune system to be activated against a potential target, that target must not only be specifically recognized by the T cell, but the T cell must simultaneously have its on-off switch triggered via one of these co-stimulatory receptors. So if this is a target that you want the immune system to destroy, an infected cell or a cancerous cell, the T cell recognizes that cell through a T cell receptor and simultaneously has its on-off switch triggered, thus turning on the immune response, which is shown in this graphic as a green light, and the immune system is activated. We have been testing reagents which prevent the on-off switch from being turned on. Recognition by the T cell without the on switch being triggered teaches the cell not to respond to that target. And that's depicted on the lower half of the graphic. This T cell has recognized, let's say, a transplanted organ tissue through the specific recognition receptor, but by administering one or several of agents that we have at our disposal that block this on-off switch signal, this T cell has not been turned on and will not marshal the immune system forces to destroy this target. We have therefore tested whether the body's immune system could be re-educated to recognize a transplanted organ as self by administering one or several of these on-off switch blockers at the time that the transplanted organ and the host T cells first encounter one another, which is immediately following the transplant. We then wish to determine that if rejection can be prevented, whether we wish to determine the durability and the specificity of that immune re-education. So let me turn the podium over to my colleague.
Thank you, Captain Harlan. Clinical transplantation has, over the past 15 years, come from an experimental procedure with very limited success to an established and successful treatment of choice for most end organ failure. Despite this advance, transplantation remains limited by the means with which we prevent rejection. Currently, transplant patients must take drugs that suppress their immune system for life. While the quality of life for transplant patients is very good, they remain burdened by the expense and side effects of lifelong immunosuppression. Our understanding of how T cells recognize foreign microbes in transplanted tissues has evolved from a very simple model where recognition equals destruction to a more controlled model governed by this second on-off switch, now known as co-stimulation. The evolution has been a result of many investigators, including research at the Naval Medical Research Institute. The mechanism described on this chart has suggested a more precise way of preventing rejection. Rather than continuous suppression of all T cells at the recognition signal, which is what the current practice is, short-term suppression of co-stimulation here could have lasting effects re-educating the immune system without interfering with cells that have already learned to respond to viruses and other harmful entities. The studies reported today in the Proceedings of the National Academy of Sciences represent a significant test of this hypothesis. In addition to Captain Harlan and myself, these studies were performed in close collaboration with Dr. Stuart Konecny from the University of Wisconsin and Dr. Tom Davis, also from the Naval Medical Research Institute, who deserve equal credit for these findings. In addition, it should be stressed, as with all advances, these studies have been built on the work of other independent investigators as well as those in the Navy. In this study, rhesus monkeys were given kidney transplants from mismatched donors. Some monkeys received no treatment. Others were treated with drugs that were designed to prevent only the co-stimulation signal, but were not given any standard immunosuppressive drugs. The co-stimulation signal blockers included a protein which blocks this binding event, as well as an antibody which blocks the upregulation of this receptor. While the kidney transplants that were performed with no treatment rejected in 5 to 7 days, those animals treated with both co-stimulation blockers had no rejection. Of greater importance, after 28 days, all treatment was withdrawn, and rejection still did not occur for up to 6 months, which was the limit of this study. This is in stark contrast to the conventional immunosuppression, where drug withdrawal will rapidly lead to rejection, often within 1 week. We also tested whether treatment with these agents that block this co-stimulation signal could reverse rejection that had already started. We found that it was effective not only in preventing rejection, but also that it could reverse rejection that had already started. We hope that this type of treatment can be developed over the next several years into a method that takes advantage of the body's ability to train its own immune system rather than to continuously suppress it. We feel one step closer to a day when the miracle that transplantation has already become can be combined with safer transient therapy. As this therapy remains in preclinical phases of investigation, it should be stressed, however, that transplant patients should continue to take their medication as directed by their transplant surgeon or physician. Captain Harlan and I will open the floor for discussions now.
Captain Harlan, before you get into too much technical questions, could you just, for the average person out there, I know that you very carefully said what it is you found, but for the average person in clear language, what exactly does this mean? Is this a significant medical breakthrough? What does this mean in average terms that you've found, and both you and also the Lieutenant Commander?
Well, I would say that really for the last 25 years, this theory called the two-signal model has been one that, and I know I'm using technical terms. I'll try to explain it in more lay terms in a moment. But this two-signal model has been one that immunologists have investigated heavily, because what it means is the ability to turn the immune system on to attack specifically what you want it to, and to prevent the immune system specifically from leaving alone what you want it to. So it really does, in my introductory comments, say this concept is being developed by us and others to direct the immune system with incredible specificity and control.
In other words, just getting it down to the heart of it, is this a medical breakthrough that will have a big step toward people who will get organ transplants?
Investigators like myself and Commander Kirk shy away from using words like medical breakthrough. I can say that we believe this is a significant advance, and that work to study this two-signal model has progressed from test tube studies to studies in rodents. But with respect to the transplantation research community at large, this is a non-toxic, short-course therapy which for long periods of time prevents the rejection of a transplanted organ, and that has not ever been done previous to this report.
Does it bother you that it's only 2 of 12 monkeys and it's the monkeys you've tested? Does that temper?
We have tested, you are correct, and you've read the manuscript, that we, for this paper, are reporting on 2 monkeys, but that the studies are continuing and are the subject of what we hope will be subsequent publications. So I'd prefer not to say anything beyond that at this point. And I will say in lay terms that you've asked for, both Dr. Kirk and I have used this line speaking with immunologists. Were we here with a dog that was speaking to you, you wouldn't say, yeah, but it's only one dog. This is something that immunologists recognized as a significant advance.
How close are you to being able to approach this with humans?
Many transplant models have been able, there have been many models that have been developed to study transplantation, and a lot of them come up with success. There are a lot of rodent models and the like. I think what is special about this paper is that it is in a species that is extraordinarily similar to humans, and that in general very accurately predicts what will happen when we move into the clinical arena. Because of these findings, our studies over the next year are designed specifically to design a clinical trial to move into the human arena. We hope that clinical trials will begin within 5 years, but that would be dependent on the studies that will be performed in the next year.
I'd like to go along with what Thelma said, to try and let the average person understand this. You have a red and a green up there. We call them a red light and a green light. Is what you're doing, are you hoping to be able to tell these T cells when to turn on and when to turn off? In other words, that you would be able to manipulate them so they would not attack transplants?
Well, the critical thing is that you're not turning all of them on or off. You're allowing the ones that have already learned to deal with the infections that you've seen all of your life to remain untouched, and only very specifically manipulating those that would attack the graft, which is not all of the T cells in your body. The specificity of this is a goal that immunologists have searched for ever since transplantation has begun, and we feel, like I say, one step closer to being able to offer the public a therapy which allows you to accept a transplanted organ as your own without interfering with the rest of your immune system.
How'd you stumble across this?
We laugh when people say stumble because we don't like to think that we stumbled over this.
My word.
This field has grown from really 25 years of work or more in understanding the activation of the T lymphocyte. People understand the central role that the T cell plays in directing complex immune responses. And this original two-signal hypothesis that apparently makes eyes glass over when I use that term, I'm sorry. But the two-signal model has been a going venture for research in immunology circles for really 20 years. And studies like these progress in a very natural way, from in vitro test tube testing to testing in rodents. And only when we understand to a fair degree what we think is happening do we take this type of technique into large animal models as we've done here.
How did you two
The Navy's been interested in this co-stimulation business for really a decade. The biochemical function of the predominant T-cell co-stimulatory receptor was a discovery made by some investigators at the Navy Medical Research Institute back in 1987. I'll mention them by name. Dr. Carl June and Dr. Craig Thompson, Dr. Jeff Ledbetter at University of Washington have made that pioneering observation a decade ago.
Now, this treatment lasts, what, about 2 weeks, the chemical cocktail that you administer?
We tried multiple different treatment regimens, and really when you move to a large animal model, you have to start from scratch at determining what the dosage regimen is going to be.
How long does it last once the treatment has stopped, or is 6 months just as far as we know?
With as far as we've gone, it's gone 6 months, and we're hoping that we'll be able to do longer-term studies over the next year. But like I said, that if you take conventional immunosuppression and stop it within a week, you've rejected. So this is a log step beyond that with regard to efficacy.
6 months without any booster?
Nothing, no.
I understand you did this out of a shoestring budget. How much did it cost you to do the study, and how much do you need to continue?
Questions like that are really very difficult when neither of us are financial experts. And as I've indicated in my introductory comments, the immune cell biology program is a broad-based research program looking at a variety of immunology-type questions. So rather than give you an answer that's imprecise, I'd rather get back to you with a more precise.
You mentioned there are other immune issues in your statement, including autoimmune diseases and cancer. Do you see future applications for this in those arenas?
While it's not the focus of what we wanted to push here today, I in fact do. About a year ago, I've already alluded to Dr. June, who I should say is retired Captain June, had a press conference that announced that kind of the flip side of this concept that we're reporting on here could be used to expand T cells or grow T cells in such a way so that you could use them to augment an immune response. And Captain June has published considerable scientific observations of some import with regard to the HIV virus infection.
Well, what about like arthritis or something where it's an autoimmune problem?
I can tell you that I got into this business because of understanding immune system function, because I've been interested in my adult life as a physician primarily in the disease type 1 diabetes, childhood diabetes, which is an immune disorder where the immune system comes in and destroys pancreatic insulin-producing cells for unknown reasons. So that's how I got interested in immunology. I certainly believe that this technology can be adapted to generate therapies that need to be tested for diseases like that, autoimmune diseases where tissue-specific cells like beta cells, pancreas insulin-producing cells are destroyed, or like arthritis or lupus.
The protein that you developed to shut down the co-stimulatory receptor, is this protein based on the characteristics of the graft itself, or is this a generic protein that can be used for any graft?
I first want to emphasize that these proteins we did not develop, and I've emphasized, as has Commander Kirk repeatedly, the collaborative nature of these studies. But to specifically address your question, you don't need to know anything specifically about the tissue that you're trying to protect from immune system destruction. You let the T cells do that job. All you have to do is put a specific target where it can be exposed to the immune cells. Let those immune cells that are designed to look for that target encounter it, but then at that point you just prevent the on-off switch from being triggered, and that T cell now has learned this must be something I'm supposed to leave alone.
Yes, sir, but my point is the protein that you're using to turn off the co-stimulatory receptor based on the specific graft, or can this protein be used for any graft in any animal?
Yeah. The beauty of this is it can be used for any recognition, not just any graft, but any tissue that's being having immune attack directed against it. So the same reagents can be used for heart, for liver, for kidney, for pancreas, for skin, for lung. Now, we have tested it in a kidney model because that is a very rigorous model. And when that system works in this type of very rigorous primate model, then it is very reasonable to think that other organ systems will come into play very similarly.
But the T cell co-stimulatory receptor in response to, say, a bacteria or a virus is unaffected by this drug.
Primarily because the T cells have already learned what to do with that. See, a transplant patient has never seen another person's tissues. And the beauty of this is that you can expose the body to these drugs precisely when they first encounter the foreign tissue.
So you're preventing the T cell from developing a memory for that particular tissue? Is that in effect?
Or we're giving it a memory that is positive, rather. So say that in the same way that your T cells, or similar to the way your T cells, when you're born, learn not to attack you. You are actually born with T cells that could, but your body teaches it not to. And what we're trying to do is mimic that type of education process later in life.
Okay, T cells learn that in the thymus. Are you, in effect, imitating what occurs in the thymus among stem cells?
The mechanisms in the thymus extend far beyond the scope of this press conference. There are probably similar mechanisms involved in the thymus, but it's also probably much more complex than that.
I assume that since you've asked about the thymus that you have a knowledge of science, and we can say that there is considerable data to suggest that there are tolerogenic mechanisms that reside outside the thymus.
Have there been any side effects on the animals that you've done these studies on? Have they had any reactions to these reagents that would be?
It's been remarkably simple. These treatments have involved a single intravenous injection to which there have been no side effects. We've seen no unusual infections. Typically, transplant patients on high-dose immunosuppression have to have sutures left in place for extended periods of time because wound healing is delayed, but that's not been the case here. Wound healing has been completely normal, as has appetite and weight gain, and so it has been remarkably straightforward.
Is one of the implications here that it wouldn't be near as important in the future to have what we now consider compatible donors? That is that, for example, in a military context, that if someone was injured in the field, rather than having to do an extensive search for a compatible donor, maybe it'd be much easier to find someone who could provide a kidney or could provide some other organ to keep that soldier or sailor alive.
We certainly believe it makes good sense, speaking from immunological terms, that a well-matched organ will always do better. But I think the implication of your study, our results suggest that what you've implied may well be true. For this study, Dr. Konechny, who was already mentioned from the University of Wisconsin, has a fairly sophisticated technique to type the rhesus monkeys to know just how distant they were. And for this study, we purposefully selected the most mismatched primates available for us, and yet this still worked.
What does this say potentially to people who are on these long lists all around the country waiting for organs?
Well, by liberalizing selection criteria, certainly that may open up more living-related donation where they're inhibited at this point because of a poor match. Anything that benefits transplantation and makes grafts that you put in last longer means that people are not rejecting and having to be retransplanted, so that lessens the burden on the waiting list. But always, as long as we are dependent on cadaveric organ donation, there will be an organ donor shortage, and people should be encouraged to discuss organ donation with their families and let people know that they would be willing to be an organ donor.
What needs to be done before this technique would be ready for testing on humans?
We are proceeding with additional what we call preclinical studies in other animal models, and we are discussing with academic collaborators just specifically what we need to do to move forward, as your question implies. So we are in the planning stage. I think it'd be inappropriate for me to say exactly what our plans are at the. We have ideas, but they're just that. Nothing. I really think that until we have those ideas formulated amongst ourselves, that it's premature to know.
Other primates?
We certainly have other primate studies planned. I would say that.
Can you pick off some of those types of primates you're talking about?
Some of the primates that we study?
Some of the others, you had one species here, primate species. What other primates?
That's the only species that we plan on studying in the immediate future, but we do have other questions that we wish to address in that species.
Such as?
I'll say that we don't yet know how well this therapy will work in the face of what is considered standard immunosuppressive therapy now. And before planning clinical studies, let me put it to you this way. If you needed a kidney transplant, and we could come to you and say, we're very good at preventing rejection right now. If you'll take these 4 medicines or these 3 medicines, there's a 90% chance that you'll do fine. On the other hand, we've got this very promising thing, but we just don't know how it's going to work in humans yet. That's a very tough question to begin to get into clinical testing, and that's the kind of question that we'd like to address in a few more preclinical studies with primates.
Is that the way you'd summarize the way that what you just said? Is that the way you'd summarize this? That you don't know. In other words, is that a good summary of your findings in that last little bit that you said?
Dr. Kirk has a great way of looking at things, so let's let him answer that.
This model is extraordinarily close to humans and extremely rigorous. Success in this model has always been an excellent predictor of how things will fare in human studies, and we have every intention of moving toward human studies with appropriate preclinical testing. In particular, patients come for transplant on a number of medications. We have to know what medications will interact with this medication, which may prevent it from working, which may augment its function. And until we know what the interaction of common drugs that are used in transplant patients will do with this, it would be inappropriate to start clinical trials. But we have every intention of moving in that direction.